Okay, I'll give everybody a chance to kind of come back in and settle back down. Thanks for the opportunity to present. I'm going to be presenting a review of peripheral blood and bone marrow morphology, and this will be focused on benign hematology. And so I wanted to spend a little bit of time talking about and review the normal bone marrow cells. So what I have here on this slide is the erythroid series. And so these red blood cell precursors are characterized by having really round nuclei. So they're fairly easy to recognize in the bone marrow. The proerythroblast over here is the earliest stage of the red blood cell precursor. It's also known as a normoblast. So these cells have very round nuclei. They have open chromatin, and they have a single prominent nucleolus, and their cytoplasm is very deeply basophilic or blue. And if you look carefully, the cytoplasm doesn't have any granularity at all. And so the erythroid precursors have a characteristic maturation sequence such that as we progress to the basophilic erythroblast stage, you start to see the nucleus become more condensed. It stays round, and the cytoplasm stays deeply basophilic. As we move over to the polychromatic erythroblast, the cells are shrinking in size, and the nucleus continues to condense. And at this stage, the cytoplasm starts to become a little less blue, and that's because of the production of hemoglobin. And then as we progress into the orthochromatic erythroblast, the nucleus is very, very tightly condensed. You can't really see any individual nuclear features. And if we look at the cytoplasm, the hue of the cytoplasm is starting to resemble that of the surrounding red blood cells because it's becoming hemoglobinized. Okay, as cells are released into the periphery, the nucleus is extruded, and we have a reticulocyte, which is characterized by a cell with no central pallor. And if you look very closely on high power, it has a very fine granularity. It's basically residual RNA that's showing these very fine blue granularity. It kind of imparts an overall blue appearance to the reticulocyte. And then we finally progress to the mature erythrocyte stage. Okay, when looking at the myeloid series, it also has a characteristic maturation pattern. So looking at the myeloblast, what we have are cells that do not have the really round nuclei that the erythroid lineage has. They have more of an irregular nucleus, but the myeloblast stage has, again, open chromatin, and they often have more than one prominent nucleoli. And sometimes people describe the chromatin as lacy. And if you look at the cytoplasm, it can be basophilic, but they often have a few small azurophilic granules to help guide you to identifying this as a myeloblast. And then as we progress to the promyelocyte stage, the nucleus stays in its open chromatin configuration, again with prominent nucleoli. It's at this stage the primary granules are expressed, and the nucleus tends to be a little more eccentrically located. As we progress to the myelocyte stage, the nucleus becomes condensed, and the secondary and tertiary granules are expressed, such that the cytoplasm looks very granular and it imparts kind of a pinkish hue to the cytoplasm. And then as we move further towards the metamyelocyte stage, the nucleus continues to condense and becomes indented. And then we move to the band stage where the nucleus is completely condensed but non-segmented. And at this stage, these cells can be released into the peripheral blood. And then, of course, with segmentation, you achieve the mature neutrophil. And they can have anywhere from 2 to 4 different segments normally. Okay, there's other normal bone marrow elements that can be sometimes confusing. I'm showing two sets of cells that sometimes are confused for one another. So on the left here, on top is the megakaryocyte, and essentially these megakaryocytes are really large, so they're easy to see, but they have a granular cytoplasm, and then they have a single polylobated nucleus. So, all the lobes of the nucleus are essentially part of one nucleus. If we look over to the right, we see an osteoclast. The osteoclast has a very similar appearance and size to the megakaryocyte. And the way to distinguish it quickly is to look at the nuclei. And if you have separate nuclei, this basically identifies an osteoclast. And then osteoblasts and plasma cells are fairly easily confused as well. Osteoblasts you usually find in clusters. They have eccentric nuclei. The nuclei are often very smooth. Whereas if you look at plasma cells, they're often found alone. And the plasma cells also have eccentric nuclei, but they have more clumped chromatin, and sometimes you can see a perinuclear Hoff zone, such as seen here, or this kind of clearing. And so these are two sets of cells that are easily confused in the bone marrow. Okay, so the format that I'm going to go on now is I'm going to show a photo of a peripheral blood or bone marrow aspirate, then present a quick clinical vignette with a question, and then show the photo again, and then we can answer the question. So I'll give each photo a few seconds for you to look at, and then I'll present the question in the vignette. So this case, the patient is a 6-year-old boy referred to a hematologist for thrombocytopenia. This patient has no bleeding history or family history of bleeding. His only other past medical history is he's got a mild high-frequency hearing loss. And so what gene is responsible for these findings? In BL2, GP1B alpha, MYH9, deletions of the long arm or chromosome 11, or GATA1. And so here's the peripheral smear again with arrows pointing to some interesting findings. And you've already seen a case of this just before lunch. So it becomes fairly easy to identify this as a case of with MYH9 mutations. So this peripheral blood smear shows macrothrombocytopenia. It has otherwise normal platelet granulation, and the neutrophils have these prominent Dolly-like cytoplasmic inclusions. So a Dolly body, you can see those in reactive neutrophils, and those consist of swollen endoplasmic reticulum. In these neutrophils, the Dolly-like inclusions are actually aggregates of ribosomes. So this smear is consistent with the May-Hegelen anomaly caused by mutations in MYH9. And this is part of a spectrum of diseases that includes Epstein syndrome, Fechner syndrome, and the May-Hegelen anomaly. And so other genetic syndromes associated with giant platelets or macrothrombocytopenia include Bernard-Soulier, gray platelet syndrome, and some cases of von Willebrand factor type 2b, and the Paris-Trousseau thrombocytopenia. And I've given the genes involved. Case 2. So this is a 4-year-old boy who's pale with intermittent jaundice and splenomegaly. Looking at his CBC, you can see that he's anemic. He has a normal MCV. His MCHC is elevated, and he has a wide red cell distribution width. And he's got a high reticulocyte count, but his DAT is negative. So the morphologic findings in this peripheral smear are found in which of the following conditions? Autoimmune hemolytic anemia, ABO hemolytic disease in the newborn, hereditary spherocytosis, or severe burns and other red cell thermal injuries, or all of the above. So here's the peripheral smear again. Really what we can see with this peripheral smear are a number of spherocytes, a number of reticulocytes, or these blue cells, indicating polychromasia, and no other abnormalities. So the answer here is all of the above. You can see these morphologic findings with all of these conditions. So as I said, the peripheral blood smear included small, dense, round microspherocytes, polychromasia, and the red cells that have central pallor is typically smaller than normal. This case that I'm showing is actually a case of hereditary spherocytosis. It's actually caused by mutations in membrane skeletal proteins, which are numerous, include ankyrin, alpha spectrin, beta spectrin, band 3, protein 4.2. And then a related condition, hereditary elliptocytosis, just to remind you, is caused by heterozygous mutations in alpha spectrin, beta spectrin, or protein 4.1. And then hereditary pyropoikilocytosis, which is essentially a severe version of hereditary elliptocytosis, is caused by homozygous mutations in alpha spectrin, beta spectrin, or protein 4.1. Here's the next peripheral smear. And the inset shows an interesting neutrophil. So this patient is a 2-month-old boy who presented with a skin abscess and he's febrile. On exam, he's noted to have silvery hair and hypopigmented skin. His CBC count is notable for neutropenia, and so the abnormality on his peripheral smear suggests abnormal lysosome biogenesis, abnormal ribosome function, abnormal phagocytosis of opsonized particles, abnormal mitochondrial activity, or impaired DNA repair activity. So here's the smear again. Notice you can see unusual inclusions in both the neutrophils as well as the lymphocytes on this smear. So the answer here is abnormal lysosomal biogenesis. This is a peripheral smear from a patient with Chediak Higashi. It shows abnormally large azurophilic or gray granules in the neutrophils and lymphocytes. And these are caused by abnormal coalesced lysosomes, and they can be found in all leukocytes. So it's due to abnormal lysosomal biogenesis. And as already been noted, patients in the stable phase have increased susceptibility to infection and oculocutaneous albinism. But there's also an accelerated phase that typically results in hemophagocytic lymphohistocytosis and can be fatal. So the other choices I gave you, diamond blackman anemia is characterized by ribosomal abnormalities. Leukocyte adhesion deficiency is characterized in part by abnormal phagocytosis in addition to migration problems. Pearson syndrome is a good example of mitochondrial activity problems. And just as one example of a syndrome that you may encounter that has abnormal DNA repair would be ataxia telangiectasia. Okay, the next smear is shown here. So it's most of the cells show this characteristic finding. But the question is, what amino acid replaces the normal glutamic acid residue at position 6 on the beta globin chain? Is it leucine, phenylalanine, glutamic acid, valine, or cysteine? And so I can show the smear again here. So this is clearly an example of sickle cell anemia. And so the normal amino acid is glutamic acid, which is a hydrophobic amino acid. It's replaced by valine at position 6 on the beta globin chain. So this peripheral blood smear actually shows a severe sickling crisis. And then you see these in patients with sickle cell disease or sickle cell beta thal genotypes. And you, as I said, you substitute normal hydrophobic glutamic acid residues for a hydrophilic glutamic acid residue for a hydrophobic valine residue. And so this leads to pathologic polymerization. And if you have a sickle cell trait, you typically do not show any sickling on a peripheral blood smear. Okay, here's the next peripheral smear. So this is a 3-month-old female presented with persistent microcytic anemia, even after a decent trial of iron supplementation. Which of the following genetic alterations is consistent with the peripheral smear findings? Mutations in RPS19 gene, mutations in codanin 1, homozygous deletions of both matripase 2 genes, transcobalamin 2 deficiency, or dihydrofolate reductase deficiency. So here's the peripheral smear again. I would characterize this peripheral smear as showing microcytic hypochromic anemia. And you can also see a number of pencil cells on there. and there's a good deal of anisoporkylocytosis, differences in the red blood cell size and shape. So the answer here is homozygous deletions of both matripase 2 genes. So this peripheral smear actually shows findings characteristic of iron deficiency anemia. Hypochromic microcytic anemia, and with elliptical cells are present, with mild thrombocytosis. So this case itself is consistent with iron refractory iron deficiency anemia. So matripase 2 normally reduces hepcidin protein expression by suppressing hemojuvelin. And so in patients with deletions of matripase 2, this leads to increases in hepcidin, which limits dietary iron absorption and causes iron sequestration. So all the other mutations I listed on there actually lead to macrocytosis. So the RPS19 mutations cause diamond blackman anemia. Codanin 1 mutations are associated with type 1 congenital dyserythropoietic anemia, and transcobalamin 2 deficiency and dihydrofolate reductase deficiency can lead to megaloblastic anemia. Here's the next peripheral smear. So this is a 3-year-old boy who presents with the findings shown in the smear. Which of the following nutritional deficiencies, if present, would explain the smear findings? Folate, cholecalciferol, thiamine, vitamin K, or alpha tocopherol? So here we have characteristic findings in the neutrophils. And so this is an example of folate deficiency where we have hypersegmentation of the neutrophils. The neutrophils have more than your normal 2 to 4 individual segment. In this case also had mild macrocytosis with occasional ovalocytes. So these are characteristic findings for advanced megaloblastic anemia, caused by either folate or cobalamin deficiency. Okay, case number 7. Here we have a peripheral smear. So this is a 16-year-old boy who had a sudden onset of headache, fatigue, dyspnea, and petechiae. His CBC revealed a WBC of 5.6. He was anemic and thrombocytopenic and had an elevated reticulocyte count. So which of the following disorders can show similar findings on peripheral blood smears? A, Shiga-toxin-mediated HUS. B, disseminated intravascular coagulation. C, complement-mediated thrombotic microangiopathy. D, systemic infection. Or E, all of the above. Okay, so here's the peripheral blood smear again. So this peripheral blood smear shows 3 major findings. You can see a large number of schistocytes, and the best schistocytes really are kind of triangular shaped red cell fragments without any central pallor. And then you can also see some polychromasia, suggesting that there may be some hemolysis going on. And there's also a notable absence of platelets. There's no platelets in this smear. So you can see microangiopathic hemolytic anemia in all of these different conditions. So as I said, this peripheral blood smear shows microangiopathic hemolytic anemia. And it's associated with several causes of thrombotic microangiopathy syndromes, including TTP, HUS, and atypical HUS. But you can also see microangiopathic hemolytic anemia in other causes, including DIC, infection, malignancy, preeclampsia, HELP, and systemic rheumatic diseases. Case number 8. Here we have a red blood cell shown on the inset. Okay, so this is a 16-year-old girl who travels on a mission trip with her family to Nigeria. Upon her return, she reports episodic fevers, and the laboratory technician calls you over to show you her findings. You state that these inclusions are most likely Kaiser-Fleischer rings, Heinz bodies, Cabot rings, Babesia microti, or malaria organisms. Okay, so these organisms, based on both the patient history and the morphologic findings, are most likely malaria organisms. So these are Plasmodium species, and usually to speciate you have to look for morphologically characteristic extracellular schizonts and gametocytes. So Cabot rings are actually rarely seen remnant microtubules of the mitotic spindle, which you can see in megaloblastic anemia, congenital dyserythropoietic anemia, and myelodysplastic syndromes. And Babesia organisms can look morphologically identical. These are ring-shaped intraerythrocytic organisms, but they're transmitted by the Ixodes scapularis tick, typically in the spring and summer in the Midwest and Southeast United States. And this clinical vignette stated that it was a winter travel to Nigeria. Okay, case 9. Okay, so this patient is a 14-year-old African-American female who presented with sudden onset of pallor, irritability, and dark-colored urine. She had a CBC notable for a very low hemoglobin level. And so the findings on this peripheral smear are consistent with hereditary spherocytosis, neuroacanthocytosis, G6-PDH deficiency, autoimmune hemolytic anemia, or thermal injury. Here's the peripheral smear again. So the answer in this case is glucose 6-phosphate dehydrogenase deficiency. So the findings are consistent because there are numerous blister cells on the smear. They're also called eccentrocytes. These cells are actually formed by the disruption of the cell membrane during removal of precipitated oxidized hemoglobin, which are also known as Heinz bodies, followed by reattachment of the two ends of the membrane and subsequent vacuole formation. In G6-PDH deficiency, you can also see bite cells when this precipitated hemoglobin is removed, but the membrane reattachment does not occur, and so it persists as a bite cell. All right, case number 10. A 16-year-old male from West Africa referred to a local hematologist because of anemia and splenomegaly. So this CBC showed anemia, MCV of 75, reticulocyte count of 152, and an elevated MCHD of 39%. So the patient's smear is consistent with what genotype? Is it hemoglobin S trait? Is it hemoglobin SC disease, hemoglobin C trait, C disease, or hemoglobin E? And an arrow is drawn to a relevant finding on the smear. Okay, so this patient is anemic, and you can see hemoglobin C crystals on the smear. So this is consistent with hemoglobin C disease. We also noted target cells, microcytosis, and reticulocytosis. And as I pointed with the arrow, there was a hemoglobin C crystal present in the center of the field. So it's actually a mutation in the beta chain of hemoglobin, which is less soluble than the normal beta chain. And this actually leads to crystallization rather than polymerization that you see with sickling. And so both the heterozygous and homozygous hemoglobin C variants actually lead to the dehydration of the red cells, and that's why you see the MCHC high in this condition. And the hemoglobin C trait does not usually cause a significant anemia. Okay, case number 11. The arrows are pointing to the finding of interest. So you're reviewing this peripheral smear in a patient with anemia, and you notice these intracellular red cell inclusions. What kind of inclusion is depicted on the slide? This is question 1. And what material is the inclusion made from? Are these Pappenheimer bodies that are made of iron protein complexes in lysosomes? Or are they Pappenheimer bodies that are made of DNA or nuclear remnants? Are they Howell-Jolly bodies, which are nuclear remnants? Are they Howell-Jolly bodies that are aggregated ribosomes with incomplete RNA degradation? Or does this represent an example of basophilic stippling, which is consisting of iron protein complexes and lysosomes? Okay, here's the peripheral smear again. So most people would recognize these as Howell-Jolly bodies pretty easily. And Howell-Jolly bodies consist of nuclear remnants, and so the material they're made of is DNA. So they are nuclear fragments left behind in the cytoplasm after extrusion of the nucleus. So we need to review the common RBC inclusions that are potentially going to show up on the board exams. So first of all, there's basophilic stippling. So basophilic stippling typically is coarse stippling, which consists of aggregated ribosomes with incompletely degraded RNA. And so you can visualize basophilic stippling with right Giemsa staining, the kind of stain that comes directly from the hematology lab. And right Giemsa staining actually allows you to identify nucleic acid. So what you're actually seeing is the RNA portion of these aggregated ribosomes. And it consists of numerous small deep blue or gray blue granules, and they're distributed evenly throughout the red cell. And so the clinical conditions associated with basophilic stippling, well, classically, you'll see questions about lead poisoning, pyrimidine 5' nucleotidase deficiency, thalassemias, hemoglobinopathies, sideroblastic anemia, MDS, congenital dyserythropoietic anemia. The Howell-Jolly body we just reviewed consists of retained nuclear material. Because it's nucleic acid, again, you can visualize this with right Giemsa staining directly from the hematology analyzers. They consist of small purple, round, very round objects of variable size. Typically you have one per cell, but sometimes you can see more than one per cell. And of course, the clinical conditions associated include either functional or anatomic asplenia, or severe hemolytic anemia, and other conditions where the spleen is essentially overwhelmed. Megaloblastic anemia, congenital dyserythropoietic anemia. And occasionally you can actually see increased Howell-Jolly body formation in newborns, especially in those born prematurely. Okay, Pappenheimer bodies. Well, these consist of lysosomes containing iron protein complexes. And so you can visualize these with right Giemsa staining, but right Giemsa does not allow you to stain iron. So what you're actually visualizing are the lysosomes. But to see the iron in these cells, you can do Prussian blue staining, which stains the iron. Typically, these are different from Howell-Jolly bodies because they're really irregular. They can either be single or a cluster of dark staining inclusions within the red cells. And they stain dark blue or black with right Giemsa, or blue with Prussian blue staining. And so clinical conditions associated with Pappenheimer bodies include asplenia, but also iron overloading conditions, such as hemolytic anemia, which is severe, thalassemias, hemoglobinopathies, megaloblastic anemia, CDA, and sideroblastic anemia. So Pappenheimer bodies are essentially lysosomes with iron protein complexes. Heinz bodies. Well, I mentioned Heinz bodies earlier. These are aggregates of denatured hemoglobin, and they usually attach to the inner membrane of the red cell. And these are not visible with normal right Giemsa staining. You actually have to use a special supravital dye, such as brilliant Crescel blue. So it's very uncommon to actually see these right out of the laboratory. These Heinz bodies are variably sized and numbered, and it depends on the rate of hemoglobin oxidation. And so the most common condition associated with Heinz bodies is G6PD-H deficiency. But you can also see with hereditary Heinz body hemolytic anemia, with oxidant drug or chemical poisoning, and rare hemoglobinopathies. Okay, hemoglobin H. So what is hemoglobin H? These are inclusions which are precipitates of excess beta tetramer chains. These are also not visible with right Giemsa staining. You can see that they're nice and evenly distributed throughout the cell. And to visualize them, you have to use a supravital dye again. And the clinical condition associated with hemoglobin H inclusions is alpha thalassemia with 3-gene deletion. Okay, so here's another case, a peripheral blood smear. So this is a 2-year-old girl who was referred to her local hematologist for anemia. The hemoglobin measured was 10.7, and what is the most likely diagnosis based on the smear? Is this an example of spherocytosis, elliptocytosis? Is this anemia of inflammation? Could it be a normal child? Or hereditary stomatocytosis? Here's the smear again. Okay, so this is an example of a completely normal peripheral blood smear. The anemia is not even significant. Hemoglobin of 10.7 in a 2-year-old girl is actually normal. And so various red cell morphologic findings like spherocytosis, stomatocytosis, schistocytes at very low levels are very common in a peripheral blood smear and are often artifactual. And so anytime you want to diagnose something as pathologic, you would like to see it at levels of greater than at least 5%. Case 13. A 12-year-old girl presents with thrombocytopenia. She had no bleeding history or family history of bleeding. The physician suspects pseudothrombocytopenia. What kind of anticoagulant can cause the in vitro platelet clumping, and what kind can be used to correct the clumping to get an accurate platelet count? Heparin and EDTA, or can it be caused by EDTA and solved with citrate? Caused by citrate, solved with EDTA? Caused by heparin, solved with oxalate? Caused by oxalate, solved by citrate. So here's the peripheral smear again, showing that there are indeed distinct platelet clumping going on here, which is consistent morphologically with pseudothrombocytopenia. So the answer here is EDTA and citrate. So platelet clumping occurs occasionally with EDTA anticoagulation and can cause the hemocytometer to undercount the number of platelets present. And EDTA can also cause platelets to adhere to leukocytes, which is called platelet satellocytosis. And so you can draw a second sample with citrate anticoagulant or even heparin anticoagulant, which should prevent this clumping and permit a more accurate platelet count. Case number 14. This is a smear from a 3-week-old boy who was referred for pallor, and his CBC showed a low hemoglobin, a low MCV, an MCHC of 29%, an RDW of 15.1%, and a reticulocyte count of 75,000. His ferritin is high, transferrin saturation is high, and TIBC is normal. So is this smear consistent with iron deficiency anemia, hemoglobin C, beta thalassemia? Is it consistent with 3-gene deletion of alpha thalassemia? Is it homozygous beta thalassemia? Or a 2-gene deletion of alpha thalassemia? So here's the smear again. And so what you can see in the inset is an example of coarse basophilic stippling. Okay, so this is an example of 3-gene deletion in alpha thalassemia. It has significant anemia, microcytosis, anisopoikilocytosis. The cells are hypochromic, and there's target cells and basophilic stippling. So the normal RDW and iron studies suggest this boy has thalassemia major rather than iron deficiency. So the 3-gene deletion of alpha thal is the best choice given the patient's age. It's also known as hemoglobin H disease, and if you did supravital staining after the patient was older than 6 months to a year, you could identify the appropriate precipitates. A 2-gene deletion is alpha thalassemia trait and not associated with significant anemia. So beta thals tend to be diagnosed after 6 months of age when the beta chain production increases and gamma chain production falls. Okay, so now we're moving on to a bone marrow biopsy. Here we have a bone marrow biopsy. So this is a bone marrow biopsy from a 17-year-old male who presented with pancytopenia. His cytogenetics were normal, and the flow cytometry was also normal. It did not identify dysplastic cell population. So which of the following additional testing should be obtained? Or the following additional testing should be obtained except A, send for telomere length evaluation, B, perform diepoxybutane testing of the bone marrow, C, evaluation for PNH clones by flow cytometry, D, cell morphology evaluation by electron microscopy, or E, hepatitis A, B, and C serological testing. So here's the bone marrow biopsy again. So the pink areas are the bony trabeculae, and then the hematopoietic space here is notably hypocellular. You can see just a small amount of residual hematopoiesis. So the correct answer here is cell morphology evaluation by electron microscopy. So this bone marrow is severely hypocellular. I would estimate it at about 5%, and it's got no evidence of a cytogenetic abnormality or dysplasia. So the biopsy is overall consistent with aplastic anemia. But the workup for aplastic anemia includes evaluation for Fanconi's anemia, DKC, evaluation for PNH clones, and hepatitis A, B, and C serologies. Electron microscopy is not useful for evaluation of aplastic anemia. Typically, you can use electron microscopy, it should say electron rather than electronic, for evaluation of congenital dyserythropoietic anemia. Case number 16. This is a 5-year-old girl who recently relocated from the Ivory Coast of West Africa, and she's being evaluated for anemia. After the hematologist reviews the peripheral blood smear, she makes a provisional diagnosis of blank and orders what additional further testing. Is this a diagnosis of sickle cell disease, and would we get osmotic fragility testing? Is this hemoglobin C disease, and would we get hemoglobin electrophoresis? Is this an example of hemoglobin E, where we're going to get osmotic fragility testing? Hemoglobin SC, where we do hemoglobin electrophoresis. Hemoglobin H disease, where we do super vital staining. Here's the peripheral blood smear again. So what the peripheral blood smear shows is a significant number of target cells and one sickled cell in the middle of the field. And so this is an example of hemoglobin SC disease, and you could confirm the diagnosis with hemoglobin electrophoresis. It shows normocytic normochromic anemia with many target cells and rare sickled cells. And the other choices that I presented would present with peripheral smears that either had more sickled cells, such as hemoglobin S disease in an acute sickling crisis, or no sickle cells with hemoglobin CC, hemoglobin H, or hemoglobin E. Okay, case number 17. Basically, I'm looking primarily at the interesting neutrophil in the middle of the field. Suffice it to say, all the neutrophils look like this. So we reviewed a peripheral smear from this otherwise healthy 10-year-old boy. We found many cells with this morphology. So this morphology results from heterozygous mutations of lamin B receptor gene, homozygous mutations of lamin B receptor gene, homozygous mutations in the Elaine gene, heterozygous mutations in SBDS gene, or homozygous mutations in the LIST gene. So when looking at this neutrophil, you can see that it's bilobed with a single strand connecting the two lobes. It's an example of a Pelger-Hewitt morphology. And Pelger-Hewitt is caused by mutations in the lamin B receptor gene. Heterozygous mutations actually cause the bilobed morphology, and homozygous mutations cause a unilobed morphology. So it's called the Pelger-Hewitt anomaly, mutations in lamin B receptor. So the other choice is the Elaine gene is associated with severe congenital neutropenia and does not have morphologic findings like that. SBDS mutations result in Shwachman-Diamond syndrome, typically not an otherwise healthy child. And the list mutations, of course, result in Chiari-Higashi syndrome. Case number 18. A 10-year-old boy presents with mild anemia and thrombocytopenia. He has bone abnormalities and hepatosplenomegaly on radiographic imaging, and abnormal cells are present on the shown bone marrow aspirate. So the molecular defect in this disease results in a deficiency of which enzyme? Beta-glucocerebrosidase, alpha hydroronidase, lysosomal acid lipase, aryl sulfatase A, or acid sphingomyelinase. So here's a picture of the bone marrow aspirate again. So this is an example of Gaucher cells, and the enzyme involved is beta-glucocerebrosidase. So these Gaucher cells are reticuloendothelial cells of the monocytic lineage, and they have lysosomes stuffed with glycosphingolipids. And the cytoplasm, as a result, has this characteristic wrinkled tissue paper appearance. And this appearance is due to these enlarged and misshapen lysosomes. And the other choices do not result in production of Gaucher cells in the marrow. Case number 19. Upon scanning a bone marrow aspirate, you note the cell depicted by the arrow. So you occasionally identify these cells with unusual nuclear configuration. What cellular process is happening? Is this an example of apoptosis, autophagy, mitosis, karyorrhexis, or meiosis? So here's the cell again. The other cells in the field look normal. And then there's a destroyed cell immediately below the cell of interest. So this is an example of a mitotic figure. It's an example of mitosis. So it's seen in cells undergoing mitosis. And in mitosis, the chromosomes condense, and you can visualize them all individually. And so it's normal to see these mitotic figures in healthy bone marrows. And you see greatly increased numbers of mitotic figures in neoplastic conditions. So it's a way for hematopathologists to get a sense of how fast a malignancy is proliferating. Case number 20. Here we have a bone marrow aspirate. So this is an aspirate from an 8-month-old infant who is acutely ill. She has a very high ferritin level. Which of the following abnormalities is shown on the photo? Is this an example of myelodysplastic syndrome, leishmaniasis, hemophagocytosis, acute monocytic leukemia, or Gaucher's disease? So here are the cells again. There are two very large cells in question in the middle of both fields. So this is a good example of hemophagocytosis. So this patient should be worked up for HLH. And the macrophage in the left panel is engulfed mature red blood cells, platelets, cellular debris. The macrophage in the right panel is engulfed in neutrophil and an immature red cell. In HLH, you tend to see the macrophages engulfing all the different lineages of cells. And it is typically more severe in cases of congenital HLH than acquired HLH. Case 21. So the red blood cell in the inset shows that it has Pappenheimer bodies. So that's not an example of coarse basophilic stippling because they're not evenly distributed throughout the cell. Those are Pappenheimer bodies. So this is a 10-year-old boy evaluated for progressive anemia, and he's noted to have hemoglobin of 7.5, a low MCV of 69, a poor reticulocyte count, high RDW, and elevated ferritin. As I noted in the inset, there are occasional Pappenheimer bodies present. So the lab results in the peripheral smear are consistent with, could this be an example of lead poisoning, homozygous hemoglobin E, severe copper deficiency, cobalamin deficiency, or sideroblastic anemia? Here's the peripheral smear again. So in this peripheral smear, we're predominantly focused on the red cells. The platelets in the field look normal, as does the one lymphocyte that's present. So this is a blood smear that would be characteristically seen in patients with sideroblastic anemia. So if we review this peripheral smear, you can see a dimorphic red cell population. One population is pale and microcytic with poikilocytosis. The other is normochromic. And you can frequently see Pappenheimer bodies and occasionally basophilic stippling because of the systemic iron overload due to chronic ineffective erythropoiesis. So if you do a Prussian blue staining of the bone marrow aspirate, in these cases you will often see ring sideroblasts. So the picture here is a picture of a red cell precursor stained with Prussian blue, so it doesn't have the normal dark blue appearance that you would see with a Wright-Giemsa stain. But Prussian blue highlights iron, and you can see that the iron granules completely circumnavigate the nucleus, which is what consists of a ring sideroblast. And then the P shows that they are Pappenheimer bodies. So genetic analysis of the case that I just showed revealed mutations in the delta aminolevulinic acid synthase gene, and this is consistent with X-linked sideroblastic anemia. Case number 22. This is a case from a 3-month-old infant who had a CBC performed, and the infant was referred to a pediatric hematologist due to the leukocyte abnormalities noted on the peripheral smear. So what class of lysosomal storage disease does this smear suggest? Could it be representative of sphingolipidosis, mucopolysaccharidosis, acid lipase deficiencies, neuronal ceroid lipofuscinosis, or metachromatic leukodystrophy? So the white cells on this smear have a very unusual pattern of granularity. The granules are larger than usual and evenly spread throughout the cytoplasm. But the predominant feature is the very large, abnormally large granules. Okay, so you can see these findings in patients that have mucopolysaccharidosis, such as Hunter or Hurler syndrome. And this prominent azurophilic granulation is seen in cases of Alder-Riley anomaly. And this finding is seen in patients with mucopolysaccharidosis where there's lysosomal buildup of mucopolysaccharide due to impaired catabolism. And there are a number of different types of mucopolysaccharidosis. Case 23. So this is a peripheral blood smear, and I've highlighted 4 cells. These 4 cells are all lymphocytes, just so you know what kind of cells we're dealing with here. So the morphologic findings in these peripheral blood cells are found in what disease category? Lysosomal storage disease, primary immunodeficiency syndromes, bone marrow failure syndromes, collagen vascular disorders, or severe systemic infections. So here's the peripheral smear again. And what you can see are lymphocytes that have very prominent cytoplasmic vacuolization. So lymphocytes normally do not have cytoplasmic vacuoles. So this is pathologic. So you would find these in lysosomal storage diseases. So there are specific disorders in this category of lysosomal storage disorder that are associated with vacuolated lymphocytes. So this particular photomicrograph that I took was a patient with galactosialidosis. But in general, if you see lymphocytes with prominent vacuolization, you should think of potential lysosomal storage disorder. Case 24. So this is a 2-month-old infant with pallor, jaundice, and splenomegaly. This CBC is notable for a hemoglobin of 7.2, MCV of 110, low MCHC of 24%, and a retic count of 210,000. What is the most likely diagnosis with this smear? Does it represent elliptocytosis, neuroacanthocytosis, pyropoikilocytosis, Southeast Asian ovalocytosis, or hereditary stomatocytosis? Here's the smear again. So this is an example of hereditary stomatocytosis. Okay, so what's a stomatocyte? Well, it's actually a uniconcave red cell that results in the central pallor that kind of looks like a slit or a slightly curved rod. So hereditary stomatocytosis is due to mutations in Rh-associated glycoprotein, and this leads to a permeable red cell that gets flooded with sodium and leads to the resulting overhydration of the cell. So the overhydration is actually the cause of the low MCHC. So diagnostic laboratory features include a peripheral smear with a lot of stomatocytes, usually more than 5% is a minimum, hemolysis, macrocytosis, a low MCHC, and a positive osmotic fragility test. Case number 25. So a 5-year-old boy gets a CBC in preparation for a tonsillectomy. The laboratory calls the findings shown on the smear. This condition is inherited in what fashion? Is it X-linked recessive, autosomal dominant, autosomal recessive, X-linked dominant, or mitochondrial? So here's the peripheral smear again. So this condition is inherited in a autosomal dominant fashion. So it's an example of hereditary elliptocytosis. There were many elliptocytes on this smear, also known as ovalocytes, a synonymous term. These are rod-shaped cells that have 2 parallel sides of equal length and 2 rounded ends, and they typically have preserved central pallor, which is helpful when you're trying to distinguish whether these are truly ovalocytes from an artifact. So normal blood smears contain a few ovalocytes or elliptocytes, but usually less than 5%. And when you see them in large numbers, it's consistent with hereditary elliptocytosis. And typically, heterozygous HE patients are usually asymptomatic. And osmotic fragility test is usually normal. And again, this is caused by mutations in alpha spectrin, beta spectrin, or protein 4.1. Case number 26. So this is an infant who presented with severe anemia, splenomegaly, and hyperbilirubinemia. After reviewing the peripheral smear, the most likely diagnosis is thalassemia intermedia, spherocytosis, sideroblastic anemia, hereditary acanthocytosis, or hereditary pyropoikilocytosis. If you look at this smear carefully, you can see that there's a great deal of variability between the red cell shape and size. So you can see schistocytes, you can see red cells that actually look like elliptocytes, and I would characterize this smear as having a high degree of poikilocytosis. So this is an example of pyropoikilocytosis, and you can see marked poikilocytosis with increased schistocytes increased elliptocytes, consistent with hereditary pyropoikilocytosis, which again is a more severe form of hereditary elliptocytosis, which is a clue to the diagnosis when you can see residual elliptocytes on the smear. When you have both parents having hereditary elliptocytosis and they each pass on an aberrant allele, you can get severe form of elliptocytosis. Okay, with that, I thank you for your attention, and I'd be happy to answer any questions later on after the sessions. I think we're ready to turn this on.